Hello, Robert Bastian. This is just an introductory talk about the use of suction drains in head and neck surgery, and it's an introduction to a potential series of discussions that I'd like to offer. I don't think this will be of interest to the general public, but there might be a few surgeons who find it interesting. And I'm not focusing on the routine postoperative use of suction drains under skin flaps, for example. I'm instead talking about ways suction drains can be used to solve big problems, such as fistulas, air leaks, and so forth. And also suction drains as a possible replacer of flaps, as I will explain. Well, why is this an important subject? Because in the hands of surgeons willing to become proficient in the use of suction drains, and it's not very hard to learn, to become sort of a suction drain whisperer, they might dramatically reduce the morbidity that their patients experience, the burden of the treatment and of the rehabilitation, and here and there on an individualized basis, the surgical magnitude of the treatment might be diminished, postoperative care spectacularly simplified, and I would argue that there might be some reduction in the need for use of flaps. I have nothing against flaps, but of course if there's a way that they're just simply not needed, I think that might be of interest. Well, here's my background. I'm not really an active head and neck surgeon at the moment. I'm a laryngologist, but in my residency at Washington University in St. Louis under Dr. Ogura of partial laryngectomy fame, we did an enormous volume of head and neck cancer surgery. So when needed, after removing the larynx or part of the larynx or other parts of the head and neck, when needed, we used local flaps and pectoralis flaps. We got very good at local closure, of course, but we used local flaps and pectoralis flaps at that time. And the modern surgeon might say, well, how primitive. Subsequently, we got the capability of doing free flaps. And it was interesting to us residents that the year after free flaps arrived, I think there was something like 100 free flaps done in that first year. And a number of us were kind of puzzled, how did we ever get along without free flaps before this capability came? And so it raised the question in our minds, is it a thing that you use because you've got it rather than because you truly need it? So now, to be fair, at that time, my program was more surgery first. We hadn't yet entered the era of chemoradiation for everything, so that almost all surgery or much of the surgery now follows chemoradiation. So, of course, healing problems would have been less back then than they are now. And so chemoradiation regime increases the need for flaps. And of course, I'm giving flaps their due. There are multiple potential benefits for either free flaps or for transfer flaps. One reason is to replace volume of tissue lost. Another is to cover vulnerable anatomy, such as an exposed carotid artery, with fresh and unradiated tissue. And another is the idea of bringing in a fresh, unradiated tissue to, in a sense, feed the damaged radiated hosting site, so that you're almost feeding the damaged area with good tissue and good blood supply that's unradiated. And then another reason was to fill holes and to deal with the problem of fistula. So with that background, lots of cancer surgery, both before and after free flaps, I want to talk about 4 creative uses for suction drains, where the suction drain becomes an actual tool in the armamentarium to solve a problem. Fistula is a big one, and that's probably the one I'll take on first. Cricopharyngeal myotomy, really useful in that context, whether the myotomy is endoscopic or transcervical. Suction drains have a very interesting use. You say endoscopic, and yes, I'll explain. And then to manage air leaks in tracheal resection, and especially cricotracheal resection, where it's hard to get an actual match because the cricoid and the trachea are so different in character and diameter and shape. To manage neck abscesses, rather than wide drainage, you can do a much more precise drainage. And then to reduce, I think I mentioned about endoscopic cricopharyngeal myotomy, you can reduce the risk of subcutaneous hair or even mediastinitis. Well, in this first video of a possible 4 or 5 that I'm going to do on this subject, I want to explain first of all the genesis of the idea and a few strands of the story. In my residency, I took care of a lot of fistulas just because of the volume of surgery that we did. I don't know whether it was across 4 years, maybe it was 6 or 8 fistulas. And boy, were they a lot of work. What happens, of course, is we have typically, like after laryngectomy, the area breakdown might be here, the triangulation stitch somewhere in here, so you have a breakdown and leakage of saliva from the interior, and then it would leak under the flap, and it would, there's an incision here, and it would come under the flap, all of the pus and the saliva and would come under the flap, and it would leak out through the incision line. And then what we would do is we would medialize and superiorize. We would make a little small incision right there at the point of the likely breakdown. We'd put a Penrose drain in, and then that person would have dressings for, sometimes it was several weeks waiting for that fistula to close. And of course, fistulas, if you've handled one, are the anaerobic smell is overpowering, and patients have to be in hospital because you're worried about carotids and so forth. So the care and the stress and duress on the patient, the length of hospitalization was terrible in some of those fistulas. Well, that's background number 1. Background number 2 is early in my career, I did some traveling for 4 months in Europe. I was interested in learning laryngeal EMG, and I also just wanted a broader exposure to the European approach to laryngology, which I understood was a little different than in America. So I spent most of my 4 months in Paris, but also a week each in Erlangen and in Marburg. Well, I was in Erlangen for EMG, but while I was there, just by happenstance, I watched famous Dr. Wolfgang Steiner remove a very large hypopharyngeal cancer using the laser. And we had done some laser work in St. Louis at WashU, but I had not seen anything quite this dramatic. I think it took quite a few hours. It might have been 4 or 6 hours even to get this done. And I remember asking him, how do you know when to stop? And I remember he answered, when the skin of the neck, when you can feel that the skin of the neck is warm. And that kind of startled me. And I remember thinking, wow, this patient has a huge internal mucosal defect. So he has he has no lining in his throat. Well, that's really what happens with a fistula. There's a leakage. There's no lining tissue. It breaks down, and so there's leakage of saliva. And then I thought to myself, well, this new thought, and of course, those hearing this, you'll say, well, yes, I mean, you hadn't had that thought before, but I hadn't. And sometimes a blinding insight arrives that's so simple that it's almost embarrassing to admit it. It's like when I was in France and I ordered steak frites one time, and for the first time, and here came this plate and I saw French fries, and I remember thinking to myself, French fries? French fries? I'd said the words together, but I had never actually thought to myself of a French origin, and of course the Belgians think they're Belgian fries. But anyway, that's the kind of obvious thought that you just don't have sometimes. Well, here's my obvious thought. It was that the new thought was that fistulas aren't so much an issue of loss of lining in the passage of saliva, that, you know, so that you got raw tissue against saliva rather than mucosa. But instead it's an issue of the flap. So you can have a big defect in the lining, as long as you don't raise a flap, there isn't a fistula. And so I began thinking about how could I do external surgery if I needed to do a laryngectomy and do it externally. How could I raise the flap but immediately return it to the circumstance as if there hadn't been a flap? So I began thinking about how to kind of make that flap stick down and almost be like there had been laser surgery. And so later at Loyola University in Chicago, I used suction drains many, many times in circumstances where today I think every head and neck surgeon would say a flap was needed, but I didn't use a flap. I used a suction drain. The most extreme case I remember was a woman, and I still remember she had liver failure, she had diabetes, she was heavily radiated and had chemotherapy. So you can't imagine worse tissue. I mean, it was just woody and horrible tissue. And I did a laryngectomy, and I didn't do a flap. And of course the issue was raised, and by then I was pretty deep into my suction drain experience, and so I said, no, I'm not gonna, I was so confident that I said, no, I'm not gonna do a flap. So what happened was, predictably, she did develop a fistula. I think it was on about day 6. So you say, okay, then you had to go do a flap. No, I didn't do a flap. I used suction drain. I think we took about 3 or 4 days in a hospital to teach her what I call drainsmanship, how to manage the drain. And then she went home with her drain. It drained horrible fistula fluid for, I think it was 6 weeks. And it was no big deal for her to take care of it. There was no smell. You know, she was home sitting and reading and walking around. She just had this suction drain managing her fistula. And she would come back to the office periodically, and and I have to go into the details of how to manage the suction drain, but she would come back in and I would shorten the drain and put it back in, and in a very I remember her skin turned sort of a dark color, and it sort of almost looked like oh, I might be wrong on this one. But she did fine. She developed a good voice. She was able to swallow. She didn't have a flap. And you say, well, that's a long time to heal it. But the point is, she wasn't in hospital. She wasn't on antibiotics. She was for the first few days. She wasn't in pain. There was no odor. There was no unusual care. It was quite simple for her to manage the drain at home and her family. And so, you know, it's a matter of choice. It could be done a different way, but all I'm doing is pointing out that there is a way of managing fistulas and other problems. I've got about 4 issues where suction drains are quite key, a part of your armamentarium to manage difficult problems in the head and neck surgery. So she had no flap, she had no hyperbaric oxygen, and I would say anybody can get that kind of result in the most challenging patient like this, provided they understand the rationale and the management of the drain. It's critical that the drain be managed, that you understand what you're doing and the sequence, and I will go into that in the... So if this is intriguing, you know, maybe this is the way you do it all the time, and there's nothing new to you, then fine. But if this intrigues you or interests you, the next video, and it'll probably be uploaded a few days after this one, will be a PowerPoint in which I'll explain, and I'll show photos and so forth, how, and I think this actual patient is in, no, she's not in the PowerPoint, but somebody else, not anywhere near as bad, but gives you the idea, is in that PowerPoint. So, there it is, suction drains as a very powerful treatment tool in head and neck surgery. Thanks for watching.